If you're uninsured now, does that mean that you get no health care?
No. In fact, many people that have no insurance are already in the system. You know, they go to urgent care. I have people here who come in who do not have insurance because of who I work for. You know, we're obligated to see anyone who comes through the door, regardless of whether they have insurance or not, because I work for a not-for-profit organization. It's not the same if it's a for-profit hospital or healthcare system. They have some obligation to the community to take care of uninsured, and then when you get to the hospital side, the uninsured are taken care of every day. And then you get into issues like cost shifting and how you pay for uninsured once they're in to a healthcare system. So there is an existing footprint that will help take care of the uninsured or the numbers that may increase once there's universal coverage. You know, but a system is already in place.
You mentioned cost shifting. How does that work?
Yeah, cost shifting is, I guess, simply put, if a person is put in the hospital for whatever reason and they have insurance coverage, then a person gets admitted without insurance coverage. Part of the charge for that person who's insured goes to cover the uninsured, and that's called cost shifting, simply put.
So we're already paying, somebody is paying
Yeah.
for the cost
Yes.
of care
Yes.
for the uninsured people
Yes.
already.
The cost shifting helps take care of some of it. In a city where you have a hospital that is not for profit and sees indigents, there's an additional amount of money that comes through CMS, Medicare. They're called disproportionate share hospitals. So they can get additional funds simply because they see a disproportionate share of people in their hospital. So that's additional funds. Hospitals who have medical students and educational training programs get additional funds because of the educational program. And a portion of those funds also are funneled into the hospital. So there are different areas where care is taken care of, and you know, most not-for-profits, in fact probably all who receive federal funds, write off quite a bit of indigent care. If you bring more people into the system, let's just say, you know, now if you have universal insurance, theoretically, yes, you will bring more people into the system, and yes, you will need additional primary care physicians, but we already know that. We know that there is a need. The issue with supply of physicians is more of what are the incentives for a medical student, for instance, to do primary care medicine. And then that gets back into economics of medical education. If you come out of medical school, you know, on a couple $100,000 a year, chances are you're not going to pick primary care. It doesn't take long for students to figure out that in primary care, you're faced with a lot of challenges, not just patients, but paperwork and insurance company requirements that impose on your ability to practice medicine. So it's not as simple as saying, well, if we have more patients insured, it's going to cause a problem with physician shortage.
Is there really that much waste and duplication that can be cut out of the current system, or would that savings drive down the level of services to patients?
Yeah, it will not drive down the level of services. There is, I would say, billions of dollars spent on repetitious ordering, on errors that are either in hospital or on medications. There, you have to factor in the amount of money that's paid for malpractice insurance and so-called defensive medicine. In a system as ours where there's not an integrated electronic record, it's easy to duplicate tests. So for instance, if I see a patient this morning, if they say, well, I was at a hospital in North Carolina yesterday and they did some blood tests, but I don't know what they are. Okay, I may be inclined to order some additional tests, not knowing what was already ordered, and I could repeat some of those tests. So you cut some of that out just by having a live electronic record where you can rapidly check to see, well, was the CAT scan ordered in North Carolina? Was the blood work I need already done at the emergency room, or was it done at urgent care because the person went there after hours the night before? So there's a lot of money in the system that can be taken out. And I think you look back at, you know, Tu Gwande and Elliot Fisher at Dartmouth, who looked at just variation in healthcare, and you find that the areas that have the highest amount of money being spent per capita on healthcare have the lowest quality. So there's a disconnect somewhere there. So you ask yourself, well, why would an area that is spending more than any place else have lower quality? And all these factors kind of play into that. Variation is a real issue, and it's how do we take the variation out of healthcare? How do we do that and at the same time not interfere with the physician's ability to practice the way he or she sees best fit? But when you have the highest cost of care in McAllen, Texas, and then you have a lower cost of care and better quality, say in San Francisco, we say there's an issue there, and there's real money that can be taken out of the system and applied someplace else. I think the other part of that is just the cost of readmissions, specifically as it relates to people on Medicare. And one of the things that Medicare did for the first time ever in July was put on their website the numbers for readmission for acute myocardial infarction, for heart failure, and you can look and compare community to community on how well hospitals are doing. And if you look at the amount of money being spent just on readmissions, it's in the billions. So then if you look at the money being spent on admissions that are maybe not appropriate, that's billions of dollars. How do we get to a point where we can pull that money out? I think a large part of it has to do with making sure people have insurance, making sure that the tests we do, the orders we write, the medicines we give have some basis in something that works. So that's called comparative effectiveness. So there's a push to do more comparative effectiveness research, and that way we know what works, maybe what doesn't work, and you can pull out some of the stuff that really is not effective or even efficacious. And there's a difference between being efficacious and being effective. So I think comparative effectiveness research is needed, and then I think taking some of the risk out of practice in terms of liability it deserves a good look. Even though the malpractice rates remain pretty stable, malpractice premiums have gone up. So I think it's worth looking back at tort reform as a part of healthcare reform and coming up with something that physicians and providers are comfortable with, in the long run decreasing some of the defensive medicine that I think to some degree we all practice.